Good afternoon, everyone. So today I would like to continue exactly from the same point that I finished last week. And this is the abnormal intracellular depositions and calcifications. So here it could be described as abnormal deposits of materials in cells, as well as in ECM, extracellular matrix, um, result of excessive intake or defective transport of or catabolism. You know that all these types of abnormal deposits could be described by four major mechanisms. Briefly and schematically, they are described here from 1 to 4. That's abnormal metabolism, and the best example is fatty liver, the lack of enzyme, then we see the accumulation of complex substrate and impossibility of transformation of this substrate into the soluble products. Thus, we got the accumulation. The best example that's lysosomal storage disease and accumulation of endogenous materials. Defect in protein folding, defect in protein transporting. In both cases, it could be caused generally by the mutations, that's the genetically determined diseases, and we see finally as a result as in accumulation of abnormal substances like proteins and possibly other substances. Then ingestion of indigestible materials or ingestion of digestible materials but in increased amount that our systems just not able to degrade them. Then we see the best example of that accumulation of exogenous materials. Let's discuss about them by the numbers and with example. First mechanism caused by inadequate removal of normal substance secondary to the defect in mechanism of packaging and transport as in fatty change like steatosis in the liver. Over here you see the histological sample as this photo of histological slide stained in with trichrome method. Why trichrome? Because there are three colors, the magenta color, deep violet, that's the staining of nuclei, the red color, the staining of cytoplasm, and the green color, the extracellular matrix. However, we can see the presence of vacuoles within the hepatocytes, and you see the mm, eccentric position of the nuclei. They just shifted to the edge of the cells. That's definitely the accumulation of fat, as you remember. The second mechanism is accumulation of abnormal endogenous substances as a result of genetic or acquired defects in the folding, packaging, transport, or secretion. There's certain mutated forms of anti-alpha-1 antitrypsin, as you may hear. The disease called alpha-1 antitrypsin deficiency. There's the hereditary disorder. In that case, we got a defect. The patient got a defect in the transporting of alpha-1 antitrypsin. So, and what, you will ask me? That leads to the continuous chronic damage of the liver on the one hand, and with that you see development of the hepatitis and then cirrhosis. You see the hepatocytes, they are abundant with the pink substance, that's the PAS D staining of the alpha-1 antitrypsin granules. Besides that, hepatocytes just can't deliver this substance outside the liver parenchyma, and all the demands of this anti-enzyme they just couldn't be satisfied, and in the organs with the increased turnover of their elastin, it could be reflected in the continuous and imminent degradation of their elastin network, elastin scaffold. Especially, it could be manifested with the development of the emphysema, and as in our emphysema of the lungs. So, the lethal outcome is imminent in that case. You see the double strike, the injury, severe injury of the liver, and severe injury of the lungs. The mechanism number 3 as the failure to degrade a metabolite due to inherited enzyme deficiencies. The resulting disorders are called storage diseases or tersaurismosis. The very good example, that's the Tay-Sachs disease. Again, that's the genetic disorder which caused by the mutation in autosome, that's autosomal disease. Then we get the lack in those patients, the homozygotes with that alleles, recessive alleles. There is a lack of the enzyme that fermentates the formation of myelin. The myelin sheet couldn't be formed in the children, and as the consequence, we see some disorders and some delay in the mental condition of the children, and finally that's lethal because there is no normal development of the central nervous system in that case. But since there is no enzyme, the substrate is still delivering into the neurons. You see the accumulation of the sphingolipids. That's the confirmation, morphological confirmation of this disease. The mechanism number 4 is considered in the deposition and accumulation of abnormal exogenous substance when the cell has neither the enzymatic machinery to degrade the substance nor the ability to transport it to the other sites. The very good example, that's the accumulation of the ink, for example, particles in the skin after the tattoo, accumulation of carbon or silica particles as an example, which is illustrated here. You see the macrophages abounded with the black particles, and finally these macrophages appeared into the pulmonary lymph node. You see, in such a way we may observe the blackening of this tissue. That's the result of the continuous chronic inhaling of aspiration of carbon particles, not only due to the tobacco smoking, but also due to the exposition to the environmental factors. Then our story will tell you about the deposition of different substances which are classified by the biochemical principle. So I would like to start from the lipids, and I want to describe you some other type of accumulations besides that those that you already discussed during the practical classes. So, well-known fatty changes, you discussed a lot about that last week. I just want to repeat that that's the story about the accumulation of free triglycerides in cells resulting from excessive intake or defective transport, often because of defects in synthesis or transport proteins. basically that's the manifestation of reversible cell injury. You know that well. Another good example, that's the cholesterol deposition. You may see that here. That's illustrated on this histological image. Cholesterol deposits in macrophages in gallbladder. However, it may appear anywhere, for example, in the skin and other organs. That's the result of defective catabolism and excessive intake in macrophages and smooth muscle cells of vessel walls in case of atherosclerosis. That's the most common example of the cholesterol deposition. So over here you can see the accumulation of cholesterol in the macrophages in the skin. That's the atheroma. Then the fatty infiltration, that's another condition which is associated with the fat accumulation. But you should understand that fatty infiltration is completely different from fatty changes, because in case of the fatty infiltration, we have deal literally with the obesity. Example, here you may see the fatty infiltration of the heart, which means the increased amount of adipose tissue in the appropriate places. And you see there growth sometimes and interdigitation of the adipose tissue with the muscles of heart, which is not good. It may provoke the, it may worsen the heart failure, for example. Over here, you just may see the increased amount of the adipose tissue in the epicardium of the heart, this yellowish tissue. And microscopically, you just may observe the increased amount of the adipocytes or increased of the size, but that's just accumulation of lipids within the appropriate place, within the adipose tissue. So that's the difference. Fatty infiltration is associated with the over accumulation, over deposition of fats within the adipose tissue, not in the parenchyma, in the stromal components. The next page, turn the page, and next page is telling the story about the deposition of proteins. You know a lot now about the different protein deposition, for example, about the reabsorbed droplets of proteins in kidney tubules due to the nephrotic syndrome, then accumulation of immunoglobulins in plasma cells, like in case of the so-called Dutcher-Russell's body. That's the manifestation of plasmacytoma, myeloma disease, or rhinoscleroma. You see this pink inclusion within the plasma cell. That's the result of overproduction of the immunoglobulins in case of the sustained chronic inflammation. And in that case, we see the overproduction and sometimes defects in the transporting and folding of immunoglobulins. That's why we see the accumulation of these proteins within the cytoplasm of the plasma cells. Okay, for sure, don't forget about the Mallory bodies, Mallory Denk bodies. It's a good example of the deposition of proteins in the hepatocytes. Deposition of glycogen basically is associated with the group of disease that we call the glycogenosis. There are many of them. Basically, they are associated with the defects or lack of enzymes that are associated with the glycogen metabolism. For example, here you see the accumulation of the glycogen in the macrophages. Accumulation of glycogen in the hepatocytes. There's the glycogen storage disease that we call Cory's disease. See, there's the fragment of the hepatic biopsy. See the hepatocytes, they are bounded with the substance, which is which looks like a clear cytoplasm, but if we will stain that with the PAS staining, it will become magenta. And you see the result of this um, continuous story. There's development of the fibrous tissue. That's already the uh, beginning of the liver cirrhosis. The next class of the substances is the pigments and deposition of pigments associated with quite interesting but still severe conditions. Typically, indigestible pigments such as carbon, lipofuscin, which is the breakdown product of lipid peroxidation, or iron, usually due to overload, case of hemosiderosis. In this gross image, see the manifestation of the bilirubin over deposition. And if you see this bilirubin over deposition in skin, we call it how? 1, 2, 3. Sure, that's jaundice. That's the photo of the patient with jaundice. You should know about several types of jaundice, like the mechanical jaundice, right? Hemolytic jaundice and the parenchymal or hepatic jaundice. So you see the jaundice, or sometimes we call it icterus, also could be revealed by the accumulation of the bilirubin in many organs, many localizations. Jaundice associated only with the accumulation of bilirubin in the skin or in the sclera. Also, you may see the presence of the bilirubin in the mucosa. And even during the autopsy, you may see the yellowish coloration of inner organs. So that's the process of bilirubin infiltration in entire body, in all tissues of our body, even in the central nervous system. Uh, Histological image illustrates the mechanical jaundice and how to approve that. You see the hepatic tissue with the dilated bile ducts, and these dilated bile ducts filled with the congested bile. See the accumulation of the bile pigments over here. So that's the result of the obstruction of the bile ducts and proximal, in the distal sides, for example, near the gallbladder, or even more distal parts. Another type of very interesting pigment, that's the lipofuscin, so-called tear and wear pigment, or pigment of aging. In fact, the formation of lipofuscin is imminent because it's basically associated with the natural degradation of our subcellular structures. But in time, the formation of lipofuscin could be significantly increased, and in the old people, the presence of this pigment could be significant. For example, in the myocardium. Cardiomyocytes over here, especially in the perinuclear areas, accumulated the golden brown pigment. You see very small granules of this pigment. Basically, they are accumulated in the complex Golgi. Then this pigment it's very hardly to remove from these cells. That's why they can continuously be present there. Grossly, accumulation of the lipofuscin could appear as so-called brown atrophy of the heart. So in fact, the accumulation of lipofuscin is strongly associated with the process that we call autophagy. During the aging, the autophagy could be increased in our somatic cells, like in myocardiocytes, and autophagy also is associated with the atrophic processes in our tissues. And then you see this overlapping of the atrophy of the cardiac tissue together with the accumulation of this brownish pigment, the brown coloration of the tissues. Finally, as a result, we call it brown atrophy. Um, Lipofuscin may appear anywhere, for example, in the hepatocytes. And besides the aging, lipofuscin is also associated with the starvation, with debilitating conditions associated with the cancer development, like the critical last stages of cancer development, which lead to the debilitating of the patient, and finally also we call this condition as cachexia. And cachexia, this severe starvation, also will lead to the increased autophagy of our cells and consequently to the increased amount of lipofuscin appearance within the cells. So you see that's the result of aging pigment in the skin. That's also accumulation of the lipofuscin. And in the iris, together with the accumulation of melanin in this patient. And the conditions which are associated with melanin, I just briefly explained the very common examples of melanin accumulation, like the moles. There's the benign lesions of the skin, which are connected with the proliferation of the melanocytes. You see over here, there's the mole and there's the pigment spot. Otherwise, so that's associated with the localized accumulation of the melanin within the melanocytes. And you see the melanocytes in the appropriate place, but not in the appropriate amount over here. So that's the skin with the nevus or pigment spot. Another important pigment deposition is associated with the hemosiderin. In fact, hemosiderin, that's the iron containing pigment. We can find it in the bone marrow. That's like the storage, normal physiological storage of iron in our body. And chemically, biochemically, hemosiderin, in fact, is the polymerized form of ferritin. So, but in some cases, the appearance of hemosiderin is associated with the pathological condition. Example is here. You see the pulmonary tissue as the alveolus and the alveoli, the wall of alveoli, and the interalveolar septa. They are quite thick. Why? Because of their chronic venous congestion. You see their enlarged capillaries filled with the red blood cells, and it's somehow associated with the appearance of this brown pigment within the alveolar space. How it's associated? So in fact, when we get the increased pressure in the microvasculature, some red blood cells just literally could be squeezed out into the alveolar spaces, and there they can be scavenged as the out of place artifacts. They can be scavenged by macrophages, and fermented onto the hemosiderin. So you may see apparently hemosiderin is the product of hemoglobin degradation. So logically, you can imagine the other possibilities of the hemosiderin synthesis. So basically, hemosiderin is the post-hemorrhagic pigment. In any place, at any place when there is a bleeding, in time, hematoma formation, in time, the hemoglobin, which appeared out of vessels, will be transformed into the hemosiderin. So hemosiderin is like the footprint of the bleeding. For example, in this case, hemosiderin appears in the kidneys. That's so-called night paroxysmal hemoglobinuria. This is the genetic disease and is associated with the hematuria, appearance of blood in the urine, and apparently the reabsorption of hemoglobin molecules from urine leads to the formation of hemosiderin directly in the renal tubuli. You see the brown coloration of them. But my question is, how do you believe me? I'm just talking, I'm telling you the story about different brown pigments, and I'm just explaining them as the different pigments, right? How could you believe me? How could you confirm that this is the different substances? In fact, there is the specific staining techniques for confirmation of certain pigment presence in our cells. For example, in case of hemosiderin, we use so-called pearls or Prussian blue staining, and in this case, in renal tubuli, like here, you see the confirmation that these blue granules, that's exactly the iron. That's the specific staining for iron. So that's definitely not the lipofuscin, definitely not the melanin. That's exactly the hemosiderin. Oh, like this, that's the hemochromatosis in the liver. You see the voila, the accumulation of iron granules within the hepatocytes. Look at this eye. It looks quite beautiful, but in fact, these two colors, that's a very, very, very bad sign. This is the sign of the so-called Wilson disease. We call it Kaiser-Fleischer-Rin, and this is the manifestation of the Wilson disease. So this green symptom, in fact, that's only the top of iceberg, because the Wilson disease is also associated with the continuous accumulation of copper in different localization. And the accumulation in the iris is the most innocent, because copper accumulation, as for example, as other heavy metal accumulation in our tissues, may lead to the activation of reactive oxygen species and imminent and irreversible damage of our cells, which may lead to necrosis and apoptosis, thus extinction of the cell population. In the liver, in case of the Wilson's disease, the continuous accumulation of copper may lead to the consequent liver cirrhosis, liver failure. But that's not the end of the story, because in case of Wilson's disease, copper accumulation may lead to the damage of neurons, and with the very serious consequences which could be revealed in the manifestation, neurological manifestation. Next chapter and next substances which are associated with intra and extracellular, both intra and extracellular accumulation. That's the pathologic calcification. Look here, there's the dystrophic calcification. Dystrophic calcification, in fact, there's deposition of calcium at sites of cell injury and necrosis. So do you remember, I guess, the from previous part of this lecture last 2 weeks ago, I told you something about the calcium-dependent mechanism of cell injury, and I told you exactly that calcium accumulation within the increased calcium concentration within the cytosol may lead to the irreversible cell injury, aka necrosis, right? So imagine that this increased concentration of calcium may result to the crystallization of calcium salts like calcium carbonate and calcium phosphate. And finally, on the place of the dead cell, literally appears the tomb of these dead cells. So you see, there's the calcium deposit. That's exactly the tombs of them. That's like uh, that's like the graveyard of the dead cells, right? So that's again another grim story, but still that's true. That's the dystrophic calcification. That's the basically the local calcification associated with the cell injury and necrosis. By the way, this is the salivary gland, and in this salivary gland there is the accumulation of calcium both in the stroma and I see the vessel and the vessel wall, and in the on the place of the necrotized acini of the salivary gland. The next type of calcification belongs to the systemic processes associated in contrast to the dystrophic calcification. It's associated with the systemic changes. Metastatic calcification sounds very bad because metastasis is basically associated with the cancer development, isn't it? However, in this case, the word metastatic just concerned with the systemic distribution of the calcium deposits in different organs out of primary localization, primary cause of the process. The same principle like in case of the cancer development, right? So basically, metastatic calcification is associated with the hypercalcemia, aka increased concentration, increased volume of calcium, value of calcium in the blood serum. So why it may happen? It may happen due to different reasons. First, that appear in my mind as the damage of the bone tissue due to osteomyelitis, this destructive inflammatory process in the bone tissue. There's the fractures, there's the bone tumors, and also the different disturbances in the calcium homeostasis associated with the hormonal function of different organs like parathyroid glands. So in case of the excess of parath hormone, we see development of the hypercalcemia. So what? Hypercalcemia, how it could be associated with the metastatic calcification? In fact, the solubility of calcium salts basically is dependent on pH of their extracellular matrix and interstitium in different organs. So then the calcium, increased value of calcium in the blood in some organs won't lead to any consequences In others, which basically, sorry, basic conditions, like literally basic conditions, basic pH more than, for example, 7.5, that may lead to the crystallization of calcium salts and formation of the metastasis. Uh, what are these organs where you may find this basic pH? That's for example, the interstitium of the lungs, and you see the formation of the metastasis in the lung interstitium. That could be the heart, arterial vessels. So paradoxically, that's the kidney and stomach. You can tell me, haha, in the stomach and kidney, we see the secretion of protons, of hydrogen ions, and that's why they see the acid conditions, acid pH in those organs. But don't forget that we're talking about interstitium. If we see the secretion of hydrogen ions, as a result, we will see the lack, the decrease of the acidity in the interstitium. That's why we see like a ricochet effect. And in organs, when we see the secretion of the acid substances, like in the stomach and kidney, in the interstitium of these organs, for sure, in case of the hypercalcemia, there is a risk of the metastatic calcification. And from this point of view, I'm over with intracellular accumulations of different substances. And I would like to discuss now about their effects, results, the end of the story about the irreversible cell injury. So, necrosis, examples. That's what I told you last 2 weeks ago, as I promised you. So, first one, that's the coagulative necrosis in the kidney, grossly and microscopically. That's exactly the fragment from here. Is in this box. An arrow just illustrates, indicates the histological confirmation that microscopically that's definitely the necrosis. So how can you see that microscopically? What is this necrosis? Necrosis means the massive death of the cells, and definitely in those cells you just can't see the single nucleus. That's like the shadows, like the shapes of the previous alive cells without any sign of the life over here. In contrast, a bit on left, you see the remnants of the alive tissue, alive renal tissue with the normal nuclei, normal cells, and between them there is the inflammatory infiltrate. That's the marginal zone, and inflammation as the response against the necrotized tissue. So that's the brief description of the necrotized tissue and necrosis in the kidney. But what exactly is going on here? What is the cause of that? Please note the wedge shape of this condition, of this necrosis. And this wedge shape, or triangle shape as you wish, indicates something interesting. So first of all, the apex, the top of this triangle, that's basically the like indication. It's pointing directly to the ischemic event, ischemic catastrophe in the supplying artery, because this type of necrosis we call infarction or infarctus, as you wish, or infarct. This is the defect, by definition, infarction, there's the ischemic necrosis. Necrosis due to the ischemic injury of the tissue. And this triangle shape is associated with the specificity, anatomical specificity of the microvasculature over here and the branching of the supplying arteries. Also, grossly, you should notice that the base of this triangle is directly faced and directly adjacent to the capsule of the kidney. So that's important to distinguish that from other types of the necrosis and exactly in the kidney. See the triangle or wedge-shaped area, the top apex just face to the ischemic injury of the artery, that's basically thrombosis or embolism, and the base of this triangle is faced to the capsule of the organ. The same approach we may observe in different organs, like in the spleen, in the lungs, in suprarenal glands, or in the small intestine. In other organs, like in the brain, the necrosis, the infarction, ischemic necrosis, looks quite different. First of all, that we see that the shape of this necrotized tissue of the brain, you see here, is irregular. There is no wedge-shaped structure over here, right? Another thing that we noticed, that in contrast to this necrosis, this necrotic event looks a bit, I would like to say wet, right? So that's becoming very soft. In contrast to the necrosis in the kidney, which is solid and quite hard, here is soft, and it's resembling the porridge. So what is the difference? Why this one is wet? Why this one is dry? In fact, these two types of the necrosis, by their condition and by the, as you wish, biochemical predisposals, we can call in different names. So this one we call coagulative, or simply simplified dry necrosis, coagulative necrosis or dry necrosis. This one is leak-effective or colliquative. Leak-effective, colliquative, that's the equal, that's synonyms, equal terms, or wet necrosis, simplified name. So leak-effective and coagulative. What is the difference? Why in one organs we see the formation of this necrosis, in others this type of necrosis? In fact, coagulative necrosis is conducted by the complete denaturation of all the enzymes, even coagulation of the lysosomal enzymes. That's why there is no activity of lysosomes, and that's why we see the direct coagulation. You just can imagine the same process in case of the boiling eggs. So the white in boiling eggs is becoming solid due to denaturation of the proteins. The same thing, you can add some lemon juice and drops, put some drops directly on the egg white, and also you will see the coagulation of the egg white due to the decreased pH. So the same thing here, due to the severe ischemic injury of the tissue, you see the coagulation of this tissue, denaturation of all the proteins, including the lysosomal enzymes. In contrast to that, in case of the development of leak-effective necrosis, basically in vast majority of cases, there is no blockage of lysosome enzymes. That's why we see the continuous self-digestion as the consequence, self-digestion of the tissues. And also some researchers report that this could be associated with the increased um, hydration of the tissue, but I don't believe that, because in fact the brain contain less water than in, for example, kidney, so it's more lipidized. I don't know, but I really like explanation. Then we have deal with the activity of lysosomal enzymes. So in case of coagulative necrosis, we have the absence of lysosomal enzymes activity. In case of leak effective necrosis, we still have some lysosomal enzymes, and that's why we have deal with the self-digestion. So, and finally, on the right bottom corner, no, right bottom image, see the lung is the lung tissue, and the gross image of the uh, so-called caseous necrosis, cheese-like or cottage cheese-like necrosis. You see, this area is associated with the tuberculosis infection. uh, Previously, it was the small affect, but finally, it was developed into this cavern, as the cavern filled with the cheesy-like substance. That's definitely looks like the cottage cheese, and that's why from Greek origin they call it caseous necrosis. Gaseous necrosis, in fact, is the result of the action of macrophages in response to the Mycobacterium tuberculosis. So the massive release of the reactive oxygen species and nitric oxide is leading to the severe damage of infected cells, infected area, and finally it leads to the formation of this type of necrosis. Caseous necrosis, by its nature, it's like it's in the middle between the coagulative and leak effective necrosis. Um, Another, okay, sorry, I turned back to the accumulations. Well, let's continue with the necrotic changes. I would like to explain them more profoundly. So, well, as you may see, I just resume the information about coagulative necrosis. That's dense necrosis may last during 2 up to 3 days, and again, it occurs when intracellular enzymes like lysosomal enzymes are denaturated. And it may appear in different organs. As I promised you, the spleen infarction, coagulative ischemic necrosis appears as in the kidney, and the same appearance in the suprarenal gland. You see again the wedge shape necrosis. Infarction in the myocardium, though, looks like in the brain by the form, but not by the consistence, because again, that's irregular in the myocardium, but uh, still, like in the kidney, it's solid and dry. That's the coagulative necrosis. You see the myocardial like this, is completely dead. You see they are with the dissolution of the nuclei and the disappearance of the membrane. Also, as a response, you see the infiltration of the neutrophils. It's inflammation. Another type of coagulative necrosis could be associated, for sure, definitely, it could be associated not only with the ischemic injury, but also with some and exogenous poisonings like the spider bite, and that's so-called loxoscerism. This is the brown spider from southern United States. See, it's quite small. It's this body is less than penny, but anyway, the bite of this spider may provoke this severe necrosis of the superficial tissues in the skin. Leak effective necrosis, like in the brain, ischemic stroke, occurs when intracellular enzymes together with leukocytes digest the tissue, and basically that's morphologically, grossly appears as wet and viscous necrosis. Leak effective necrosis could be secondary, like in case of the lung abscess. You see the cavity. Previously, it was filled with the pus, and pus, in fact, has the morphological appearance of the leak effective necrosis, and as the microscopic appearance of the lung abscess. You see a lot of dead leukocytes together with dead pulmonary tissue cells. So they are mixed together, and there is no order in this mess for sure. Caseous necrosis, as I told you before, and microscopically it appears as a necrosis. You see the desert, no alive cells, just pink empty space. What does it mean pink? It means that there are some proteins, degraded proteins, and they could be stained with the eosine, but still no nuclei. That's the dead cells, the graveyard, as I told you before. Another type of necrosis that's quite specific, so-called fat necrosis. Fat necrosis is the result of the necrotizing event in the adipose tissue with the release of calcium ion, with the digestion of lipids, and finally interaction of fatty acids with calcium, with the formation of the calcium salts of fatty acids. In fact, you should know that calcium salts of or calcium or sodium, potassium salts of fatty acids we call soaps, real soap, and thus the process of formation of these salts, even with calcium, we call saponification. So fat necrosis, that's the result of saponification of fatty acids, which could be released due to the enzymatic digestion of them. But how, why this necrosis may appear? You see it again as the adipose tissue, which is surrounding the pancreas with some inflammatory infiltration. So what is the origin of this necrosis? What is the cause of that? In fact, that's the result of the massive release of the enzymes from the pancreas due to the pancreatic damage. Okay, for example, acute pancreatitis, pancreonecrosis is commonly associated with the fat necrosis in the surrounding adipose tissue. And grossly, I want to notice you, grossly it appears as so-called chalk spots. Chalk spots, they are whitish because again, I told you, due to the saponification or soap formation. Soap, for sure, that's not real soap. Another type of infarction, there's the bowel infarction in the small intestine. That's the red infarction. In this case, necrosis is associated with the massive hemorrhages. We will discuss about this phenomenon later in the topic of circulatory disorders. However, I want to notice that in this case, in bowel infarction, there is the wedge-shaped infarction. This one is basically leak effective. with hemorrhages, since that it's red infarction, but also when the microbes, anaerobic bacteria are contaminating the areas of this necrosis, we have dealt with another phenomenon, the formation of the gangrene. And from this point, I want to explain you this. Gangrene, in fact, is not only there's not simply the necrosis, which could be characterized by the specific type of the or biochemical mechanism of the tissue destruction or localization. That's the coincidence of two events. First, necrosis of any origin, of any causative agent, and contamination by the anaerobic germs, anaerobic bacteria. In this case, the necrotized tissue also is treated with the anaerobic bacteria, and in that case, we have deal with the formation of the iron sulfide. Iron sulfide leads to the black coloration of the tissues, and this blackening, this black coloration of tissues, is that's what we call gangrene. Here you see the food with the gangrene. This gangrene is wet. It's developed due to the ischemic injury of the food tissues due to the atherosclerosis. Occlusion of main artery led to the ischemic event here, and consequently the bacteria from external environment contaminated the necrotized tissue, and that led to the development of the gangrene. You see, that's another point of view of gangrene of the leg. That's already amputated leg, and you see the gangrene in the tissues, in the soft tissues of that. That's very plethoric. See, enlarged, soft, and for sure this decay of tissues led to the very bad odor. Another type of the necrosis, that's the fibrinoid necrosis. Fibrinoid necrosis mainly associated with the autoimmune diseases. In that case, we have deal not only with the necrosis of tissues, necrosis of extracellular matrix, basically in the vessels, but also with the infiltration of these necrotized compartments with the antibodies and immune complexes involved into these autoimmune processes. But here in this image, you see another case of fibrinoid necrosis. I just want to point you here. You see there's the intensive pink reddish areas, intensive eosinophilic areas, we call it, right? And that's exactly the sign of the fibrinoid necrosis. You see there's the amorphous masses again. But this case of fibrinoid necrosis is normal. That's the normal, I would like to say, physiological appearance of fibrinoid necrosis. You may ask me how, where, when the necrosis could be normal. I will respond you, yes, it could be normal in case of the pregnancy. See, that's the formation of the just formation of placenta. That's the villi of the chorion, and you see there's the syncytial and cytotrophoblast. They just release some enzymes, and they're trying to prepare the placenta for the future development of the embryo, then fetus. So that's the normal appearance of fibrinoid necrosis. Necrosis, that seems very dramatic, even tragic way of killing of the cell. You see, normal cell is passing the threshold of point of irreversibility, without any chance of recovery. Progressive injury of the cell leads to the breakdown of plasma membrane or organelles, nucleus, leakage of contents, and you see the amorphous appearance of the cell that's just like a blast necrosis. And as a result, you see I repeated many times that there is the response against the necrotizing events, that's the inflammation. Again, due to the release of all inner compartments from the cells to outside, it may induce the inflammatory response. But there is another way of the cellular death, which may be conducted very, very, very silently, without any noise, without any blast. This is the apoptosis. Apoptosis, that's from Greek again, could be translated as the fall, like an autumn fall. And that's exactly what's going on with the cells. Some cells, which may look normal due to certain events, certain triggers within or outside the cell, suddenly, will be transformed into the apoptotic bodies, many of them. And finally, these apoptotic bodies are just phagocytized by neighboring cells or special cells, phagocytes, and literally cell just disappearing. Why so? What are the triggers and what are the pathways, mechanisms of apoptosis I want to describe briefly here? In fact, apoptosis may appear, um, so it's physiological condition. In fact, in many tissues, many organs, the cellular population of our cells is regulated by two opposite processes. First, the proliferation of the cells. Second, the apoptosis. And this balance supports and sustains our homeostasis. However, in some cases, apoptosis may exceed the normal value, and that's why we have dealt with the pathological apoptosis, and I will explain them particularly in different cases, in different diseases. Now you should know about two pathways of apoptosis. That's intrinsic or mitochondrial pathway, which depends on the balance between pro-apoptotic and anti-apoptotic proteins, BCL family. They are located in mitochondria and they are dependent on other factors which may provoke disbalance between them. For example, some mutations in the nucleus may signalize about the problem and induce pro-apoptotic proteins. That's good for cell because some unrepairable mutations could be eliminated only with elimination of the cell. Otherwise, this accumulation of mutation may lead to the cancer development, right? So that's important mechanism. So BCL family of pro-apoptotic effectors like BAC destabilize the inner membrane of mitochondria and provoke the release of cytochrome C. Cytochrome C, in its turn, that's the organizer of the apoptosome, and this apoptosome produce initiation, like the cascade initiation, like avalanche initiation of caspases. Caspases could be regulatory, like initiator caspases, and executioner caspases. These executioner caspases, in fact, that's enzymes that start to dissect the cell releasing it, breakdown of cytoskeleton, cutting the nucleus into the fragments, the formation of cytoplasmatic blebs, and finally, with that, there is the formation of apoptotic bodies. And cell literally is uh, disappearing. Apoptotic body by apoptotic body, it's dissolving, and the apoptotic bodies are phagocytized by the macrophages or neighboring cells. Another, that's intrinsic pathway. Extrinsic pathway got another triggers. It's associated with so-called death domain. That's the receptor on the surface of any nucleated cells, in our cell in our body, contain this red button of self-destruction on the surface, and after interaction with the specific receptors on the surface, for example, of T cells, other immune cells, or neighboring cells, finally may produce the same triggering effect with initiation of the regulatory caspases, then activation of executioner caspases, and the same story, fragmentation of the cell into the apoptotic bodies, and finally recognizing of these apoptotic bodies with the specific ligands to phagocytic cells. So you see, that's very silent death without any noise, and as I told you, it doesn't produce any inflammation. Now you may know why, because of the integrity of the membrane. That's an important point. You see the different examples of apoptosis. For example, on the left, there is the electron micrograph of the B cells, which are under the process of so-called clonal selection. That's the normal process that appears during the formation of specific immune response. In that case, the most successful clone of B cells will survive and will continue to produce the most successful antibodies against the bacteria or virus, whatever. And the others, B cells, the other clones of B cells which are not so successful will be eliminated by apoptosis. That's physiological process, almost physiological, because anyway it's associated with the pathogen induction. And the apoptosis in this case is triggered by the dendritic cells. This is the another example of apoptosis. That's apoptosis of the squamous epithelium. So the renewal of our physiological regeneration of our epidermis exactly is depending on the apoptosis on the outer layer of the epidermis. However, the cellular death, now we know that, is not limited only within the two forms, necrosis and apoptosis. Now, researchers look at that much wider, and they consider the necrosis and apoptosis into the much wider terms, like so-called accidental cellular death and regulated cellular death. And necrosis, it's like accidental cellular death. Apoptosis, like regulated cellular death. But in fact, regulated cellular death may appear with both necrotic and apoptotic morphology. And you see there are many types of them. For example, necroptosis. That's something like a mixture between the necrosis and apoptosis. Immune-dependent cellular death. You see, autophagy-dependent cellular death. Mitosis, we will discuss about them in topic of inflammation. Mitosis, like the directly the apoptosis or disappearance of the cell within another cell. Pyroptosis and others. Like necroptosis. In this case, I want to explain briefly what is that. That resembles necrosis morphologically and apoptosis mechanistically as a form of programmed cell death. Necroptosis is triggered by a ligation of tumor necrosis factor receptor 1 and viral proteins of RNA and DNA viruses. So you see, you may consider that as the viral induced apoptosis or programmed cell death, like that. Necroptosis is the caspase, though that's caspase independent, but dependent on signaling by so-called RIP1 and RIP3 complex. Finally, this RIP1 and RIP3 complex, they are combined into the necrosome, in contrast to apoptosome, remember, in apoptosis, and that leads to the metabolic alteration in mitochondria, and consequently to the same events like in case of necrosis. So you see, it's beginning like in case of apoptosis, almost with some regulatory pathways, but finally it releases into the mass like in case of the necrosis. Autophagy, that's another form of at least partial cell death, which involves sequestration of cellular organelles into cytoplasmatic autophagic vacuoles or autophagosomes that fuse with lysosomes and digest the enclosed material. Autophagy is an adaptive response that is enhanced during nutrient deprivation, allowing the cells to cannibalize itself to survive. That's why we call it autophagy, self-eating. Autophagosome formation is regulated by more than a dozen proteins that act in a coordinated and sequential manner, and dysregulation of autophagy occurs in many disease states, including cancers, inflammatory bowel disease, and neurodegenerative disorders. Autophagy plays a role in host defense against certain microbes, like in case of the tuberculosis. So, best example, clinical examples of where autophagy is involved. That's cancer. And autophagy can both promote cancer growth and act as a defense against cancers. Neurodegenerative disorders, many of them are associated with dysregulation of autophagy, like in case of Alzheimer's disease, there is the accelerated formation of autophagosomes, and in contrast to that, Huntington disease, we see that mutant protein huntingtin impairs autophagy. Infectious diseases, there is the involvement of autophagy, and many pathogens could be degraded by autophagy. What I told you before, that's tuberculosis, shigellosis, and human simplex, herpes simplex virus infection. In this case, then the microbe is evading the normal way of the digestion by the cells. The autophagy is like the last straw to digest the evading tricky bacterial wells. And also there is the approval that autophagy is involved into the development of the Crohn's disease. Thank you for your attention. I hope it was useful. I wish you to have a good week. Please join our channel, subscribe and like. Have a nice week. Bye bye.